We are having two sessions. That is, session one, a talk by three consultants, and uh, followed by a panel discussion. In that, the topic is from symptoms to solutions by demystifying acid peptic disorders. It is introduced by Dr. Ismail Siad, lead senior consultant at Astromedicity. He's the alumni of Chandigarh and Chandigarh Medical College, and 20 years experience in gastroenterology, including more than 15 years teaching experience in medical college. Also, Dr. Binoy Sebastian, senior consultant in Medical Trust Hospital, and Dr. Anthony Paul Chettupura, senior consultant in VPS Lakeshore Hospital. Talk will be followed by the panel discussion by the same consultants. So now I invite Dr. Ismail Siad to the dais and conduct the session. Dr. Ismail Siad.
Good evening, friends. Myself, Dr. Ismail Siad, President of Cochin Cut Club, would first like to thank the Association of Physicians of India, Cochin chapter, for the invite. We have Dr. Shibi Matthew, who is the Secretary of Cochin Cut Club, and past secretaries Dr. Anthony Paul Chettupura and Binoy Sebastian with us to deliver the talk and panel discussion. We thought of discussing some common problems which we encounter in day-to-day practice, that is acid peptic disorders. And we have two talks and one panel discussion. To deliver the first talk, I invite Dr. Binoy Sebastian, Senior Consultant, Medical Trust Hospital, on GRT. Over to you, Binoy.
Good evening, dear friends. First of all, let us express our gratitude to the APA Cochin chapter for giving us this opportunity. As you all know, gastroesophageal reflux disease is a very common problem. It simply means reflux of gastric contents. It could be bile, it could be acid, it could be food residues into the esophagus, which can lead to troublesome symptoms, signs, and complications. So this is defined by the Montreal Consensus as a condition which develops when the reflux of gastric contents goes into the esophagus, producing signs, symptoms, or complications. So it's one of the most common GI problems. I would say organic GI problem. The commonest GI problem for which somebody comes to consultants would be a functional bowel disease. But this is the most common organic problem. And in India, the prevalence is about 9%. So we all see a lot of cases and we think that this is only gas, this is only acidity. It's a very benign problem, but need not be a benign problem all the time. So it can lead to complications like peptic stricture. It's a benign stricture, but they come with dysphagia. They have a lot of, the quality of life can be affected. This can lead to something called Barrett's esophagitis, where you can see the lower end of the esophagus is replaced by the lower normal esophageal mucosa is replaced by gastric lining. So that can actually lead to ultimately adenocarcinoma. Though these complications are there, they are quite rare. Only up to 2% of the population might develop peptic stricture. Thanks to the treatment, we have very effective acid suppressive medications nowadays. Barrett's esophagus actually seen up to 2% of people who come with the symptoms, and during endoscopy we find it in 2%, but if you look into the endoscopy positive population, the percentage may be up to 15%. And the risk of carcinoma in Barrett's esophagus is only 0.1 to 0.5% annually. Though the literature says up to 0.5%, in our experience, probably not in this part of the world, we are not seeing that many cases of adenocarcinoma arising from Barrett's. So what exactly is the pathophysiology of GERD? And I'm just taking you back to the anatomy classes. So we have an esophagus. It crosses the diaphragm through a hiatus, enters the abdomen, where it continues the stomach. So we have a kind of putative hypothetical valve called lower esophageal sphincter, which is separating the stomach from the esophagus. And the sphincter in the normal resting position, it is closed. This has a normal resting tone, so that the sphincter is closed. So when you eat something, the swallow induces opening of the reflex. The food goes inside, it closes again. So whenever the tone is lost, whenever the integrity of this apparatus is lost, you get reflex. So there are three important mechanisms. One is hypotension of the LES. Second one is hiatus hernia. When there is a herniation of the stomach into the esophagus through a loose hiatus, that can actually affect the anatomy of the apparatus and can lead to reflux. And the third phenomenon is something called transient lower esophageal sphincter relaxation. I will be discussing it in another slide. So the normal resting pressure is up to 30 millimeters of mercury in relation to the intragastric pressure. So there is a positive pressure. So there are a lot of things which can actually lead to LES hypotension, including the various kind of food which we eat. The classical examples are chocolates, mints, spicy food, a lot of oil, sweets, citrus fruits. The many drugs which are commonly prescribed, like calcium channel blockers, nitrates, benzodiazepines, they all can relax the sphincter. Obesity can relax the sphincter. Even smoking, alcohol, pregnancy, certain medical conditions like scleroderma, all these can lead to LES hypotension. If you look at hiatal hernia, actually you can see that in the cartoon. This is the portion of the stomach which is migrating into the thoracic cavity. So these diaphragmatic crura become loose. The apparatus as such becomes weak. The pressure comes down. So, and one more thing is the esophagus is no longer, lower end of the esophagus is no longer an intra-abdominal structure. It becomes an intrathoracic structure and forms a pouch where there will be a reservoir of acid. So the acid will be there and it leads to a kind of re-reflex phenomenon. So even if you give PPI, that cannot suppress the acid which is collected there. So all these things can actually perpetuate an ongoing reflex program. Then comes transient lower esophageal sphincter relaxation. It's actually a physiological phenomenon which is happening normally. This is nothing but the burping reflex. We all burp. When there is a distance from the proximal stomach, the air is vented out through a normal phenomenon. So this is the most common cause of ongoing reflex. We all have this transient lower esophageal sphincter relaxation, which is actually mediated through GABA receptors. And this is the most important cause of GRD. So now coming to the clinical features, GRD can have typical esophageal manifestations as well as little atypical but common extraesophageal manifestations. So typical symptoms are heartburn, acid eructation. Sometimes they come with chest pain. Sometimes they can have frank regurgitation of food. And when you do an endoscopy, you find erosions. You can see linear erosions in the lower end of the esophagus. Then there is an entity called non-erosive reflux disease. The person comes with typical symptoms of heartburn, regurgitation, but when you do an endoscopy, the endoscopy is normal. There are no erosions, absolutely normal G junction. So in up to 50% of cases, you get this phenotype where typical symptoms but normal endoscopy. So this is called non-erosive reflux disease, and notoriously it is more difficult to treat than a reflux classical erosive esophagitis. Then a host of extraesophageal symptoms. They come with a chronic cough. They can have LPRD, laryngopharyngeal reflex syndrome, which can produce voice changes, ongoing laryngitis, foreign body sensation. Sometimes they come with asthma. They can have dental erosions. They go to ENT doctor with sinusitis, recurrent pharyngitis, even pulmonary fibrosis and otitis media. So some of them are established associations, some of them are proposed associations. So how do you diagnose GRD? So it's often an office-based clinical diagnosis based on typical symptoms, and often, many a time we tend to start such patients on PPA. And if the person responds to PPA, if the symptoms comes down with the PPA, this itself will tell you that this is GRD, and many a time the diagnosis is made. But sometimes, the person may not show a classical response. Sometimes we may not be able to stop the PPA. Sometimes the symptoms are very atypical. So in these situations, probably we tend to send the patient for endoscopy. So what are the indications? So if the diagnosis is uncertain, or if there are the so-called alarm symptoms and signs, like if there is dysphagia, odynophagia, if there is weight loss, blood loss, recurrent vomiting, or somebody who's absolutely normal comes with a new onset of symptoms, particularly if the person is above the age of 44 or 50, then probably it is better to do an endoscopy and make sure that you are dealing with the GRD and nothing else. And another class of patients who actually do not respond to PPI or acid suppressive medications, and if the symptoms are long standing, to look for complications like virus esophagitis or even development of an early adenocarcinoma, you have to do an endoscopy. So once you make a diagnosis, once you do an endoscopy, then how do you treat? Of course, there is a role for various lifestyle modifications. There are a lot of triggers. As I said, the food can trigger your lifestyle. Your habits can trigger. If you're obese, you have to reduce your weight. And particularly if you have nocturnal symptoms, if you wake up from sleep with reflux disease, then avoid lying down to sleep immediately after food. Give at least 2 to 3 hours of gap before your bedtime. So the dinner should be taken either early or go to bed late. And we can actually elevate your head and with either keeping a block at the head post, or you can have reflex pillows. And there are a lot of medications. We have antacids, H2 receptor blockers, proton pump inhibitors, and now the new kits in the block, potassium competitive acid blockers or the PCAPs, and prokinetic drugs. The treatment of choice is acid suppression, and this is best achieved by either proton pump inhibitors or now the PCAPs. So again, a lot of drugs, starting with omeprazole, lansoprazole, pantoprazole, esomeprazole, rabiprazole, and now we have the newest drug which came to market is onoprazan. So these are the equivalent doses. So which drug to choose from? In fact, there is no definite advantage or disadvantage for a particular drug. So it's your choice probably. And this is a recent meta-analysis on onoprazan in persons who had severe grade C, grade D esophagitis, where they compared onoprazan with PPI in for inducing remission or as initial treatment as well as maintenance treatment, and they found that the efficacy and safety is actually superior to PPI with onoprazan. Antacids are needed or used only to control the symptoms on a SOS basis. It's not used as a long-term therapy, and actually doesn't produce any mucosal healing. The H2 receptor blockers were the drugs probably 30-40 years ago. We have ranitidine and famotidine still going strong, where if you look into the healing rates, they are inferior to PPA. The only situation maybe you can combine it with PPA if the person has nocturnal symptoms. And in pregnancy and lactation, of course, now PPAs are also being used. Then these group of drugs, the prokinetics, the drugs which actually empties the stomach and increases the LDL stone. We have metoclopramide, domperidone, etopride, citalopram, levosulfide, even macrolide antibiotics. And the basis of using these drugs are they are shown to increases the tone of the sphincter, they improves gastric emptying. But if you look into the literature, the evidence to support the use of these drugs in GERD is very weak, and definitely they are not recommended as monotherapy, and probably only in very selected cases you need to use it as an add-on therapy. So the drug of choice is acid suppressive medication, either PPA or PCAP, and the combination therapy is not advocated or promoted. And there are a lot of evidences where they found that if you combine PPA with a prokinetic, probably there is some improvement in symptoms, but there is no definite mucosal healing or endoscopic response. Another study where they actually, it is a meta-analysis, 14 studies were included. They also concluded that inclusion of a prokinetic improves symptoms but no significant effect on mucosal healing. So the verdict is there is no role for a prokinetic along with the PPA. And unfortunately, many a time the practice is to use a combination therapy rather than using two drugs. We have a lot of PPA with either D or L or IT. Unfortunately, there is no evidence, and definitely it adds to cost. It is a polypharmacy, and it's not necessary. The same purpose is achieved by a single drug. There is no need or reason to combine these two medicines. And now we have a patient who has symptoms of reflux. You did an endoscopy. We found some endoscopic evidence of reflux. The patient is put on PPA, but still he is not responding. Then how do you go about? What could be the reasons? So there are a lot of possibilities. It could be poor compliance. The person probably may not be taking the drugs in the proper way, or it could be something called eosinophilic esophagitis. So this is a situation where you have an allergic esophagitis, which can actually present somewhat similar to endoscopic, so the conventional reflux disease, or it could be something called bile reflux. So it need not be acid all the time. So it could be duodenal-gastric reflux. It could be bile rather than acid. And if you give an acid suppressive therapy, the bile reflux will not respond. Or another common situation is a functional heartburn. So the person may be having typical symptoms, but there may not be an actual reflex, actual acid reflex. Or it could be a reflex, but esophagus will be hypersensitive. So these situations should be addressed in a different way. So there are a lot of other situations where the person may not respond. So in such situations, in order to get a clarity on the diagnosis, to make a confirmed diagnosis, we may have to go for 24 esophageal pH monitoring. Sometimes impedance studies. Impedance studies will tell you whether it is acid, whether it is weak acid, whether it is bile, whether it is air which is coming up, and it will give you an idea about the proximal extent of the reflex. So a combination of pH monitoring and impedance will tell you what exactly is happening. And in certain situations, we may have to do a manometry also to exactly assess the esophageal motor function. So this is not routinely done. Mostly it is a clinical diagnosis, endoscopy in most of the situation, but only in certain situation when the person is not responding to PPA, or if the diagnosis is not sure, you need to do all this in either more pH metry or impedance metry. But it should be done definitely before a surgical procedure or endoscopic procedure, because you have to be 100% sure that you are dealing with a true reflex. The surgeries, it's called fundoplication. Now it's a laparoscopic procedure mostly. So what the surgeon does is, the surgeon actually reduces the hiatal hernia. There is a wrap around the G junction, so the G junction becomes very tight. The diaphragmatic crura is approximated, and the esophagus is pulled down into the stomach. It becomes an intra-abdominal structure, so that the integrity of the lower esophageal sphincter is retained. Now the future. So we have acid suppressive medications, we have surgical techniques. Then I have initially discussed about transient lower esophageal sphincter relaxations. So it is in fact the most common mechanism of reflux, and baclofen has shown to modulate these transient esophageal relaxations, and there are a lot of data on use of baclofen. Probably it comes handy when you have bile reflux than an acid reflux, where acid suppression may not work. The problem with the baclofen is it's not a suitable drug for long-term use, probably 2 to 3 months. So you start with the 10 milligram and slowly can go up to 20 milligram TAD. Then endotherapy. There are various endoscopic techniques with which you can actually augment or strengthen the lower esophageal sphincter. We can use thermal ablation like Stretta procedure, and with endoscopic gadgets we can make plications, we can suture, we can tighten the lower esophageal sphincter. So these are still early days. A lot of modifications are going on. Newer and newer gadgets are coming. So definitely a day will come, probably the surgeons, or rather endoscopists, will call shots in correcting the lower esophageal sphincter. So this is another procedure where you can actually ablate the G junction. You can see there is a gap, lax G junction. You make a submucosal injection so that the mucosa is lifted up. Then you ablate the mucosa either with dissection or with laser, and fibrosis will actually tighten the sphincter. This is called anti-reflex mucosectomy. So to summarize, gastroesophageal reflux disease is a common problem. The diagnosis is often made in the OPD, but they can have atypical presentations and often can have overlap with other GI disorders, especially a functional heartburn or functional reflex. Sometimes we need to have a detailed evaluation, particularly if you're planning for a endoscopic or a surgical intervention, and the treatment is always with acid suppressants. So start with a single dose, single drug, single dose. combination therapy only in certain selected situations like associated gastroparesis if there is vomiting as a dominant syndrome symptom. So this pathway is a new potential for various drugs. Baclofen is already there. Surgery and endoscopy probably in selected cases. Thank you.
Thank you, Binoy. We will take questions at the end. Next, we have a talk by Dr. Anthony Paul Chittipura, Senior Consultant Gastroenterology at Lakeshore Hospital. He will talk on dyspepsia.
Thank you, Ismail. I am API Kerala chapter member since 25 years, but this is the first API meeting I am attending. And only API meeting I attended during my PG as Epicon in Lucknow in 97. So thank you for the invitation. I can see a lot of familiar face in this crowd. Okay, my topic is dyspepsia. In this crowd, who never experienced dyspepsia? Can you raise your hand? How many people are taking PP at least once a week in this group? And I am taking. So let's digest some facts. Dyspepsia. Many people complain like bloat, gas, flatulence, abdominal pain, all come under an umbrella called dyspepsia. We have structural dyspepsia, as Binay was mentioning, peptic ulcer disease, CS stomach, and we have non-GI cause of symptoms like coronary artery disease, muscular pain. Even in my two of my MBBS classmates, dyspepsia not responding to PPI, they ended up with stents in their heart. So then we have something called functional dyspepsia. So our talk today is mainly tailored towards functional dyspepsia. So there is no structural cause in general. So regarding this, this all started long time back about these early reports. In 1910, you can see they're talking about anxiety, they're talking about gastritis, they're talking about fermentation, motility disturbance. Then the name functional dyspepsia actually is given by this Mayo Clinic physician called Alvarez. Earlier it is called Alvarez syndrome, hysteria, neurotic functional dyspepsia and all. You know, hysteria, earlier during MBBS time, most of the time you write hysteria. Hysteria actual name come from uterus. Initial people are thinking that because of the uterus, all the problem happened in their with their mind. So this is the global prevalence of functional dyspepsia. You can see entire continents having symptoms, and the bubbles, small bubbles, are the countries where they have. This is from the systematic review and meta-analysis published this year. So quality of life, you can see subject with chronic dyspepsia, all their they have low positive well-being, depressed mood, self-control, general health, vitality. Everything is more than the normal subjects. And these are the symptoms they can have, like epigastric pain, fullness, postprandial fullness, bloating, nausea, early satiation, belching, vomiting, or weight loss. If there is a weight loss, it is not, you have to consider something else, but weight loss can happen with long-term chronic dyspepsia. Or the abdominal complaints are functional dyspepsia. Yeah, we have differential like irritable bowel syndrome, biliary pain, pancreatitis, malabsorption, infections, and malignancies, which can mimic functional bowel disease. How there is some criteria called Rome criteria. So actually, the people who are interested in dyspepsia, they sit in Rome to formulate this the definition. That's why it's called Rome criteria. Now, currently, we are having Rome 4 criteria, which is in 2016. In 2026, we are going to Rome 5, and the name has been changed from functional dyspepsia is going to become a disorder of gut-brain interaction, DGBI. That is the newer name for all these functional diseases. So in this, one or more of the following, like bothersome postprandial fullness, early sedation, epigastric pain, epigastric burning, and no evidence of structural disease that is likely to explain the symptoms. And criteria fulfilled for the last 3 months with symptoms onset at least 6 months before the diagnosis. So you should have some symptoms of 3 months, and it should have at least 6 months duration should be there. That is, then only you can call functional dyspepsia. And this dyspepsia have two components. One is called epigastric pain syndrome, and other is postprandial distress syndrome. In pain syndrome, at least one of the symptoms, at least a day a week should have this pain, and must include one or both the following at least 3 days a week. That is mainly for publication purpose, main these days and all. But in practical purpose, we know they may have symptoms for some time. They have interval of asymptomatic period, then they can episodic symptoms. So the prevalence among the community-based study, postprandial distress syndrome is around 60%, and epigastric pain around 37%. And in referral population, again, postprandial distress in around 38%, and epigastric pain syndrome in around 26%. So gallstones can gallstone comes as dyspepsia. Usually they come with pain. Even though it's not a colic, we call it biliary colic for biliary pain. It's not a colicky like ureteric or this intestinal colic where you get episodic pain. Biliary pain is a continuous pain. You can see from that graph that this blue thing is a continuous pain, and it lasts for at least 36 hours. It goes up, it lasts for 6 months, and it comes down. It may be associated with nausea and vomiting, interscapular pain, right shoulder pain, and sweating. Indigestion cause functional dyspepsia. Malabsorption or maldigestion. Dyspepsia, as you know, it's a Latin word from dyspepsia, from dyspeptus, difficult to digest. So dyspepsia is mainly indigestion. It's another name called dyspepsia. So, but malabsorption syndromes like chronic diarrhea, steatorrhea, weight loss, macronutrient deficiency, it all can have little bit of dyspepsia symptoms. And can the food associate symptoms induction or exacerbation? Yes, there are certain foods which can lead to dyspepsia, like fatty foods, milk and dairy, alcohol, coffee, red meat, carbonated drinks, some vegetables, spicy foods, carbohydrates, and wheat and citrus. These all foods can precipitate dyspepsia symptoms. Are there increased production of gas? Yeah, bloating symptom is around, you can see in around 54 to 57%. Visible abdominal distension, like seen in 36% of the patients, with rumbling and postprandial discomfort. Do the patient with bloating have more gas volume within the gut? There are a lot of 5 studies which shows there is no bloating, more gas volume, no gas volume. And this is because there are two types. So this is perception scale. We have subjective symptom and we have objective symptom. We can see that patients have severe objective or this subjective symptoms is more. Severity of symptoms is more in people with this functional dyspepsia. Thus, functional dyspepsia means ulcer or malignancy. You can see this is a cause of dyspepsia in 3 studies were shown that most common cause of dyspepsia is still the functional, then followed by esophagitis, peptic ulcer, and gastric cancer. And this is both okay. This Asian study and Western study, they found that in endoscopic patients, most of the dyspepsia patients, it's a normal, followed by a little bit of patient with a peptic ulcer. That is light blue is peptic ulcer. Can the drugs cause dyspepsia? Yes, most of the drugs can cause dyspepsia, and these are the most commonest drug I am just mentioning here. Metformin, which is a commonly used antidiabetic. Most of the patients they come with dyspepsia. Acarbose, antibiotics definitely, steroids, NSAIDs, theophylline, iron, and biphosphonates. Does alarm feature means malignancy? There are alarm features of red flag. We have to concerned about the patient. That is the time we have to send the patient for referral for endoscopy. If age of onset is more than 55 years, overt GI bleeding including melanoerythematosus, evidence of iron deficiency anemia, dysphagia, persistent vomiting, unintentional weight loss, family history of cancer, especially gastric and esophageal cancer, palpable mass. So, is there any value for this symptom? There is this study, systematic review shows that alarm features have limited predictive value for underlying malignancy. Their use in dyspepsia management strategies need further refinement and study. So, about the alarm feature, low positive predictive value for diagnosis of organic disease. Consensus is to investigate further. OGD is the diagnostic modality of choice. Selected case, if OGD is negative, you can use ultrasound or CT and other blood test and stool for parasites. Does PPA relieves all dyspepsia? This is Dr. Binoy has mentioned PPA can be given for GRD, but is there any role in dyspepsia? This is initially is a meta-analysis of 7 trials. Modest benefit versus placebo. Around 40% patients have response to PPA. A benefits mainly confined to epigastric pain syndrome, as I mentioned earlier. There are only one negative result from Asian Hong Kong study, and recent Hong Kong RCT showed no benefit. And again, Singapore open label study, no benefit. Multiple studies, no benefit of high dose versus standard dose. There's some benefit with PPA, but not, you can't increase the dose. Does H. pylori cause dyspepsia? Large population studies, increased incidence of H. pylori infection is seen in functional dyspepsia, and there is significance is unclear. So Cochrane meta-analysis showed significant symptom relief with RR of 10%. Then there are 2 trials. One is HEROES trial, which shows eradication have 50% improvement in 1 year. And there is another meta-analysis of 10 RCTs, no benefit compared with placebo. So yes or no. Then this is another forest plot showing H. pylori and functional dyspepsia. Eradication therapy beats placebo, but this is non-specific antibiotic effect. Functional means there is no physiological basis. Is there any physiological basis? As I said, Rome, 4 criteria. The name is going to change, disorders of gut-brain interaction. So definitely there is a psychosocial conceptual model is there. Early life, you have genetics, culture, environment, then psychosocial factors, then we have physiology, all lead to functional gastrointestinal disorder. And there is a brain gut axis, both CNS and our enteric system is involved. We do have some problem in duodenum. There is one study which shows there is some more incidence of eosinophils in the duodenum. And does it cause symptoms? Yes, there are certain symptoms like early satiety, retching, retrosternal pain has been seen more with this eosinophilic infiltration. Does post-infection infection cause functional dyspepsia? Some post-infectious cases, especially there are certain studies with rotavirus, Giardia, Salmonella, Campylobacter cause associated post-infectious functional disorder. Then what happens? There's abnormal fundic relaxation in response to meal in 40% of functional dyspepsia. There are study shows that in dyspepsia, 40% they have impaired fundic accommodation with the redistribution of food to antrum. It can lead to postprandial distress syndrome. So impaired 1/3 we have impaired fundic accommodation, functional dyspepsia with early satiety. If there is delayed gastric emptying, correlates very poorly with symptoms, and hypersensitive to gastric distension, functional dyspepsia with pain. And this is another study which showed gastric emptying is abnormal in population-based dyspeptic subjects. We can see there is gastric emptying of healthy donors versus those without GI symptoms and patients. They have more of gastric emptying is abnormal in patients with functional dyspepsia. Does treatment means lots of side effects? The drugs for the dyspepsia is there from the century old, more than century old. We have a lot of treatment available for dyspepsia. Even the Coca-Cola and Pepsi is actually manufactured for dyspeptic symptoms during that time. At that time they had alcohol and even I think marijuana in that drinks. Later on they made into a recreational, a normal drink. Then we have drug action, acid suppressant drugs, fundic relaxant drugs, and prokinetic drugs all have some action on the dyspepsia. And we have prokinetic drug, as Dr. Binoy mentioned, doesn't have much in GRD, but have some mention with the gastroparetic dyspepsia. Then we have fund relaxing drug, again, this postprandial distress syndrome, and acid suppressant drug PPI, and newer PCAPs also in the market have some effect. And centrally acting neuromodulators, mainly tricyclic antidepressants, levosulfuron, mirtazapine, have some effect. And we are all concerned about the safety of PPIs, whether it affect the cardiovascular, bone fracture, dementia, chronic kidney infection. It's overrated actually. And we can see there are a lot of studies shows that very, very minimal, absolute and relative risk of long-term PPI is very minimal effect on the kidneys, dementia, brain, bone, etc. The safety concern of prokinetics, like extrapyramidal symptoms, Parkinsonism, galactoria, and your cardiac symptoms like arrhythmia, QT prolongation. And this is just the algorithm for the dyspepsia. So uninvestigated dyspepsia. If you have alarm features, go ahead with the upper GI endoscopy. You have finding, treat the organic dyspepsia. And if there is no alarm feature, we can non-invasive test for H. pylori. It is positive. We can treat that and look for the response after 4 weeks. And similarly, you can give empirical therapy with PPI. Check, wait for 4 weeks. If no response, go ahead with endoscopy and follow this. Then this is how functional dyspepsia is suspected. First, H. pylori test and eradication if not done. And dietary modification, that's also very important, dietary modification. In predominant symptoms, epigastric pain or burning, you can have proton pump inhibitor with or without prokinetic agents. And you have to give for 4 to 8 weeks and see. If there is no response, try antidepressant anxiolytic therapy. If there is no response, you have to look deeper for other organic diseases. So, ladies and gentlemen, you may be surprised how many want their indigestion tablet deep fried in batter. That is about dyspepsia. Thank you for your patience.
Thank you, Anthony. Next, we have the panel discussion by the eminent panel. Dr. Shibi Matthew, Senior Consultant Gastroenterologist from Lisi Hospital, Dr. Binoy from Medical Trust, and Dr. Anthony. If you have a patient with acid peptic disorders, do you do any lab tests? You have a patient who has come to the OPD, and if you're doing some lab tests, which lab tests will you do?
In fact, there is no specific lab test to confirm or diagnose acid peptic disease. These lab tests are primarily to exclude other causes, like sometimes it could be a biliary pathology, sometimes it may be a pancreatic pathology, it could even be a cardiac problem. So those mimickers can be identified by using various lab tests. I mean, when you said lab test, I thought it would be a blood test. So there is no blood test, and then we have seen that in his algorithm, Dr. Anthony showed looking for H. pylori, because we know that H. pylori is the most common cause of ulcer disease. And how do you diagnose H. pylori? We have a serology where the serology will only tell you there is a previous exposure to H. pylori, the antibodies. It won't tell you, or it won't say whether there's an active infection. For that, probably you need to do a breath test or a stool antigen test. So there is no definite role for serology, or rather, you should not go by serology. If possible, do an endoscopy and find out whether there's an ulcer, whether there's a esophagitis or a cancer even. But if you want to do H. pylori test, then a stool test would be the best.
Okay, then the role of endoscopy has already been elucidated, so we will go H. pylori also we have looked into. Now, Dr. Binoy, what are the factors which increase the risk of peptic ulcer disease in patient with taking low dose aspirin or NSAIDs? A lot of patients are taking aspirin. Even diabetics will take as prophylaxis with aspirin. So, is there is a chance for increased risk of peptic ulcer disease?
See, the second most common cause of ulcers, as you all know, are drugs. So, and the drugs are NSAIDs and aspirin or clopidogrel, those group of drugs. The risk is include elderly people if the person had any ulcer in the past, particularly if there was a complicated ulcer, suppose like a bleed or ulcer perforation, then the risk of getting another ulcer is high. Or if the person is on NSAIDs, especially a combination of NSAIDs, or if they are taking NSAIDs along with an antiplatelet drug, or NSAIDs along with anticoagulants or steroids, and elderly people associated comorbidities, and if there is an H. pylori infection, and if they are smokers and alcoholics. So these are the group of people who are having more risk with NSAIDs or aspirin.
Dr. Shibi, do corticosteroids increase the risk of ulcer disease? We know that they produce dyspepsia from Dr. Anthony's talk, but do they produce ulcer disease?
The answer is no. Actually, studies have shown that corticosteroids per se will not increase the risk of ulcer disease, but it is seen that if corticosteroids are prescribed along with the NSAIDs, there is increased chance of ulcer and ulcer-related complications than when compared with those patients which are who are taking only NSAIDs. So this happens with the patients who are on long-term treatment for arthritis, etc. What about GRD? Corticosteroids, theoretically, it has been shown to decrease the LES tone. This studies have regarding GRD and corticosteroids are mainly in patients with the bronchial asthma patients with the GRD symptoms. So in those patients who are taking steroids, it has seen that there is increased exposure of the esophageal mucosa to the acid, and probably that is a cause of GERD. Steroids has also been implicated along with the many other factors. So this GERD in bronchial asthma patients, it can again exacerbate asthmatic symptoms. That is a vicious cycle.
Okay, thank you. Smoking, alcohol, etc., has been already talked about. Now, Dr. Anthony, what are the drugs you have mentioned, but what are the usual drugs for acid peptic disorders?
Yeah, we all know that acid is actually produced with this parietal cell. If you see the cartoon, we can see that there is something called proton pump, that is hydrogen potassium ATPase, that is called proton pump. This produces the hydrogen into the lumen, where chloride will also come, it produces hydrochloric acid. So mainly this PPA is actually PPA block this proton pump called hydrogen potassium ATPase. Next. So this is the evolution of acid suppressing drug. Earlier we had H2 receptor antagonist, and by 1988 we had omeprazole. Then lansoprazole came to the market. In 94 pantoprazole came, and 99 driprazole came. By 2000 esomeprazole came, and now in 15 actually this, PCAPs came actually in Japan. In India only it came last year.
So we have got a lot of drugs actually to treat acid peptic disorders. Role of prokinetics has already been talked. We always see when one looks into the prescription, we see PPA is often co-prescribed with any drugs. Like people will be prescribing antibiotics, they will co-prescribe PPIs. Is it necessary, Dr. Binoy?
Is it necessary? I just wanted to get the opinion of the house. Yeah, I mean, I'm sure everybody will be agreeing, it is actually not necessary, but unfortunately, all of us we are all doing. That is a confession which even gastroenterologists like us also would actually make. So if you look into the literature of most widely prescribed drugs, PPA is number 4. Opioids, NSAIDs, then statins, and the fourth one is PPA. And in 2003, in America, it became an over-the-counter preparation. So it is easy, though it is for a restricted period. It is easy to get PPA. And the PPA prescription has increased by 15% over time. And if you look at elderly population, almost 40% of people are on PPAs. and 60 to 70% of these prescriptions are actually unnecessary. Next. So this is just a Google search, and over prescription of proton pump inhibitors, and there are a lot of papers. So over prescription or unnecessary prescription actually increases the cost. It becomes a polypharmacy, and there are a lot of side effects. And many a time what happens is now it is a super specialty era. So a patient will be meeting different doctors. So there will be a cardiology problem. Cardiologist will be seeing, a neurologist will be seeing, then an orthopedician will be seeing. Each person, each doctor might give a, so orthopedician might give an NSAID. So to protect a PPI will be added. The person will be on aspirin to cover that. Another PPI will be added. So that particular patient will be taking 2 or 3 different PPAs from different doctors. If I mean these things do happen actually. So in order to because this has become a real public health problem, American Gastroenterology Association came with a slide an update and as well as guidelines on how to prescribe proton pump inhibitors. In fact, there are multiple recommendations. The key recommendations are we should be having a regular audits and analysis and clearly document the indication of giving PPA. So if the patient comes to OPD, at least go through the prescriptions and see whether they are getting PPAs and if the indications are actually real and genuine. And another unnecessary mistake which we all make is these PPAs are meant for once daily dosing. It is not necessary or needed to give twice daily. So if it is BD, make it OD and try to de-prescribe. Either you can abruptly stop or you can actually taper it and stop. And the last recommendation, and it's an important recommendation, the decision to stop PPI is not because of the concern of side effects. So if it is necessary, give it. There is no hesitancy in giving, but only thing is it should be for a clear indication.
And Dr. Anthony, how if you start acid suppressants, how long should you continue it?
The recommendation is for 4 to 8 weeks. We start with OD dose for 4 weeks and see whether the patient responds or not. If not responding, make it double dose for another 4 weeks. If not responding, then you have to reassess the situation.
Okay, so it should be usually a short
Yeah, then
the patient
then as
symptoms.
you said, you have tried to de-escalate the medication. If patient cannot have a lot of symptoms, then I'll ask them to get SOS treatment. Whenever they get symptoms, ask them to take one.
So if the patient has got GRD, which is continuing, how long will you continue?
Either you get to low dose for long term, or ask them to take alternate day like that. You have to make
So the lowest possible dose. Okay. Now it has already been talked about, but let us see. These are some of the TV advertisements in the West. Actually, people are calling for legal attorneys and advocates are
pump inhibitor such as Nexium, Prilosec, or Prevacid to treat heartburn, indigestion, gastritis, or acid reflux. In a recent study reported by CNN, data from the U.S. Department of Veteran Affairs was used to compare people who used a proton pump inhibitor, or PPI, with an alternative known as histamine H2 receptor blockers. The researchers found that patients who took PPIs had a 96% increased risk of developing kidney failure and a 28% increased risk of chronic kidney disease. If you or a loved one has been diagnosed with chronic kidney disease, acute kidney injury, renal or kidney failure, acute interstitial nephritis, dialysis treatment, kidney removal or transplant surgery, or related death while taking a PPI, you may be entitled to compensation. Protect yourself and fight for the compensation you deserve. You choose the right legal team that has the experience, support staff, and resources to seek the most compensation for your injuries. Call for more information and a free case review.
So
This is a
we might come across in future illegal implications in prescribing these drugs. So is it actually Dr. Anthony has shown that the actual effect is actually less. But can you, Dr. Binoy, can you enumerate some of these side effects? And is it really real?
Yeah, there are a lot of side effects being mentioned, starting from as shown in the video. interstitial nephritis, then it is shown that it can actually lead to malabsorption of iron, vitamin B12, magnesium, calcium, which might lead to fractures, anemia, increased infections, particularly enteric infections like Clostridium difficile, and then pneumonias, particularly if you are using in the ICU. Next slide. But then, the data on all these side effects, all these concerns, there is definitely a theoretical backup. Each side effect can be explained with a lot of theory, but the data on all these side effects are actually very shaky. One of the most feared side effect was interaction with the clopidogrel. So many people who were discharged following a cardiac event they came back with the cardiac events, and they found that those patients were taking a PPA, but it was based on a case sheet based retrospective analysis. So in order to have a causality, you should be having a randomized, prospective, controlled, well-designed trials. So most of the side effects are actually lacking concrete data. And having said that, definitely there is a noise, there is a problem. So that is the reason why we say PPA should be prescribed on a judicious basis, selected basis. Try to give the minimum dose whenever possible. Avoid unnecessary prescriptions. For example, it is not necessary to give it along with an antibiotic. It doesn't help at all. So, but this is a study where they found that they actually looked into the side effects of PPA. More than 17,000 people were enrolled, where the patients were on Roxban and aspirin. So two groups. So one group, around 9,000 patients received pantoprazole, and the second group was placebo. So and data was collected for 3 years, every 6 months, particularly looking at the PPA side effects. And they found that only concern was increased enteric infections with PPA. So this is a kind of properly designed prospective control trial where they found that the side effects were not that high. So the message is there is a concern. So you should be using your PPA judiciously, and it should be used whenever it is necessary.
So, actually, as Anthony has shown, the absolute excess risk is actually very minimal, and these drugs can be safely used. And we have got experience for the last 3 decades of PPA use. And if you PPAs are good, Dr. Shippy, why you need a new drug like potassium competitive acid blocker, and or what are the unmet needs in the treatment of acid peptic disease?
When we consider PPI as a treatment for acidic disorders like GRD, ulcer disease, we need to keep in mind that there are two aspects that we need to consider. One is the compliance of the patient, how compliant is with the PPI. Second is the nocturnal acid breakthrough. Uh, Before going into the details, I will tell you how PPI acts. PPI is actually a drug which needs some time to bind to the proton pumper. That is, it has to be taken 30 to 60 minutes before food. PPI acts by decreasing the meal induced acid secretion. So it has to be taken 30 to 60 minutes before food. So if taken 30 to 60 minutes before food, in that time it will reach the canaliculi of the parietal cells and bind to the proton pumps. So all these proton pumps may not be active at a time. So it gets active at different points of time in the day. But it is seen that the majority, the vast number of PPA, I mean proton pumps are active just before the first meal of the day. So you have to take the PPI 30 to 60 minutes before the first meal of the day. That is the ideal situation. So in that case also only 70 percentage of the proton pumps will be active. So with the PPA you can block up to 70 percentage of the proton pumps. So half-life of the PPIs are also less, 1 to 2 hours. So after that it will not, it acts actually covalent bonding and blocks that. So second thing is that nocturnal acid breakthrough. By definition, nocturnal acid breakthrough is that during the night time, even patients on a PPA during the night time, patient's gastric pH goes below 4 for a period of up to 60 minutes. In that case, the patient is considered to have nocturnal acid breakthrough. In GRD patients on once daily PPI, it is seen that around 70% of patients get this nocturnal acid breakthrough. And those who are on BD dose also, it gets around 30% of patients get nocturnal acid breakthrough. It actually causes a reflux, disturbs the sleep, and all those symptoms can happen. So to overcome this, there are 3 points to consider. The once daily dose may be made twice daily dose. Twice daily also, as I told, 30% increased nocturnal acid breakthrough is there. Second is that to add an H2 receptor blocker at the night time. So, but over time, H2 receptor blocker response comes down. That is what is seen. Third is to get a long-acting drug which can act for 24 hours. So, as already mentioned, there are certain unmet needs with the PPIs, which to the points which I described. It should be a fast-acting drug. It should not food should not interfere with the intake. Complaints will increase with the once daily dose. Potent drug, 24 hours action. It can overcome the nocturnal acid breakthrough, etc. So we need a better drug to answer these unmet needs.
And so we have now the potassium competitive acid blockers. Dr. Anthony, can you enumerate on PCAPs?
Yeah, he just mentioned this PCAPs. In a single day, last 2-3 months, single day, at least 8 medical reps come with Vonopressor prescriptions. So much drugs. I think at least 10 to 12 companies that they come with this Vonopressor. This is a first generation, I think, PCAP. There are many other PCAPs on the pipeline, which is going to come. So now this has come. As he said, there is some unmet needs for the PPI, which it can, whether it fulfills that need. So in PPI, as he mentioned, we'll take 5 to 7 doses for the maximum inhibition. 1% start with the first dose. Onset action is slow in PPI. It is rapid here. PPI is actually a prodrug, which has to convert to active for action. This is a direct drug. Acid stable is not stable. This is stable. pH more than 5 holding time, 60%, 85%. H. pylori eradication with 1% shown to be better than the PPI eradication. And healing rate, especially in grade CD esophagitis, it's 82%, 92% with 1% comparing with PPI. And healing rate across the board, it is again better than the PPI. Intrapatient variability is less with 1%, but there is more with PPI because of the CYP C19.
With the advent of PCAPs, what is a paradigm shift that has occurred in the treatment of H. pylori?
See, the conventional H. pylori treatment, as you all know, is actually it's not a patient-friendly regime at all. Very cumbersome. We have to have 2 antibiotics in very high doses, amoxicillin and clarithromycin, the conventional, along with the PPI, and sometimes we add bismuth also to this regime for 10 to 14 days. I think at least 30 to 40% patients will come back and say, I can't tolerate these drugs. So, 1% with the advent, what paradigm shift it has made? As it is shown, these drugs are more potent and they act very fast. So, the most important thing to kill or hit a bacteria is the bacteria should be actively multiplying. So, actively multiplying bacteria is targeted by the antibiotics more easily. So, when the acid suppression occurs and the pH increases, there will be more multiplying bacteria. So the antibiotics will become more effective there. Along with that, the efficacy of antibiotics also will be better in a low pH situation. So in these two things actually adds to the beauty of 1% based combinations. Can I have the next slide? So there are data on 1% amoxicillin dual therapy instead of triple therapy. And in fact, there are 2-3 meta-analysis where they compared this 1% amoxicillin as well as clarithromycin triple therapy. It is compared to conventional triple therapy with PPA. So they found that this dual therapy, in fact, is as good as conventional triple therapy or 1% based triple therapy. So probably the duration can be reduced to 7 days. So now instead of having 3 or 4 drugs, we can treat H. pylori with just 2 drugs for 7 days. So the data is very promising. In fact, this has to be translated into, this is all from Western countries, particularly from, not only from Western countries, mostly from Japan. So it is early days for us, we just started using it. So let us see how it works. If it is working, then it is really a promising and, as Dr. Ismail said, a paradigm shift.
And now coming to the PCAP safety, as with PPI, there are also some concerns with PCAPs. And from the we know that Japanese has been using it for a long time, from 2015. And from the registry, Japanese adverse drug event report, it has shown that these patients also can have nephrotoxicity, especially with tubulointerstitial nephritis, but it is as equal as PPI only. And also in patients, these are population-based studies where they looked into 11 million people who have taken PCAPs, compared with H2 receptor antagonist and PPI. There are also some concern about because of the acid suppression, atrophic gastritis developing carcinoma of the stomach, but it is as equal, similar to that of PPI. So there are some concerns, so we should be using it judiciously. And that comes to the end of the panel discussion. Any questions from the floor is welcome.
Dr. Binay has already mentioned during this GRD the talk, is actually symptomatic relief. So initial symptomatic relief, it is this oral antacid, especially alginate, that can be used for nighttime dose too. There is something called, what is that, RAF formation, which prevents the acid to come up into the esophagus. This alginate.
There is what's known as the acid pocket. When you take food, the acid goes up and it becomes a pocket. So there is more chance for reflux. This arginate will actually cause a raft and will prevent the reflux of acid. And symptomatic relief also with antacids. But if you really want to heal the erosions, you have to take some acid suppressants.
If patient can take oral, definitely oral is preferred. Injectable is mainly patient with GI bleed who are in ICU or in room. Then we give injectable PPI.
Some of the areas where vonoprazan scores more than PPI is, one is severe esophagitis. Second is in Helicobacter pylori eradication. Third is in severe acid conditions like Solon-Galeason syndrome. Third is if you are doing some endotherapy like cutting to prevent bleeding from these. In these areas, actually, vonoprazan scores more than PPI.
Yes, 10, I think 10 rupees, 20 rupees. Saying comparable to PP only.
Thank you, panelists, for a nice discussion. It was very enlightening, common topic, but a lot of uncommon things surfaced. I would like to make one or two comments first. That is, one of our old professors with wisdom. All knowledgeable people are not having wisdom. That's the problem now. A professor with wisdom who he used to say, when you are deciding to prescribe acid suppressing medications in a smoker who is above 60, at least take an ECG. At least, if not a TMT, because they have burnt their fingers by misdiagnosing coronary artery disease. And sometimes it may even be diffuse esophageal spasm, which even responds to nitrates. So there is a gray area in that, and he used to be always particular that we shouldn't overdiagnose. As clearly mentioned, GRD before ruling out other common central chest pain causes. This was one of the messages which he gave and passed away. This is one comment. The second comment is some people prescribe even now with PPI and antacid together. This has got a problem according to pharmacologists. The absorption is reduced by 30 to 40%. So PPI with antacid together at the same time has to be avoided. And then another thing, a few years back, we had a heated, because physicians discuss only with heat. So we had a heated discussion, which PPI. And then everybody said all are same, all are same. And we asked the kings of medicines, the pharmacology department, and they dwell deep into the literature, what only they know, we don't know them, pharmac-related literature, and they came up with an answer, pantoprazole. Not because of the acid suppression capacity, but the drug interactions are least with pantoprazole. That was the time only rabiprazole was available above pantoprazole. So this is one information they gave. with a lot of research. So I just want to pass this. Thank you very
But
much.
I think Riboprazole has the minimal interaction because that doesn't it doesn't go through that CYP C19. Riboprazole least CYP related.
Yeah, this was almost that era when rabiprazole was just
The concern was basically because omeprazole, which suppresses cytochrome P450. So there is a lot of inhibition, metabolic inhibition of the metabolism of other drugs.
I have one more question regarding the use of PPI in the ICU. The colonization of bacteria theory. Does it still hold good?
Yes.
Still holds good. As far as possible, avoid giving high doses of PPA. Many a time it is PPA twice daily, injectables, and it will be continued just like that. So there is data on PPA suppressing the acid and increased VAP and lung infections.
Okay, thank you.
In a anti-H. pylori treatment, actually, we are seeing that the traditional triple drug therapy, it's found to be becoming more and more resistant because of clarithromycin and metronidazole resistance, which is increasing. So we are forced to start with the quadruple therapy in areas with high resistance. So, but it is seen that vonoprazan being very highly potent, vonoprazan combination with the triple drug therapy or even with amoxicillin has got a more than 90% H. pylori eradication rate. So that is promising, but we need more data on that.
I think we have got another session also. We'll stop here. We are over exceeded time. Thank you. So yeah. No, there can be small bowel bacterial overgrowth. It's okay.
Yeah, in fact, PPA can increase the small intestinal bacterial overload. It can modulate the colonic bacteria as well. It is there, but again, how far it is going to be affecting the gut microbiome to a meaningful level, we are not sure.
So one last question. I have to Shibi sir regarding the chronic steroid use. Sir, for Cushing syndrome, even now among the manifestations, gastric ulcer is being described as one of the common symptoms of Cushing syndrome. So isn't Cushing syndrome like a chronic steroid use? So
Cushing syndrome can cause ulcers, but corticosteroid per se, right now data doesn't feel that actually corticosteroids are directly associated with any ulcer formation. But there may be confounding factors, like if the patient is taking some small amount of NSAID also. If NSAID use also is there, corticosteroids combined use, it can increase the risk of ulcer. So compared with those patients who are using only NSAIDs, that comparison is there. NSAID versus NSAID plus steroids, there is increased risk. But per se, it has not been shown.
One thing you should understand that Cushing's is a hyper-exaggerated state of hormone, whereas when we treat, actually it will be in a therapeutic dose, and we will be stopping. We won't give it for long term. So most often that may be the reason why it. Okay, then thank you once again.
Thank you, the team of gastroenterologists, Dr. Uh, Ismail Siad, Dr. Binoy Sebastian, Dr. Anthony Paul, and Dr. CB for the excellent presentation and clearing all our doubts regarding the gastroesophageal reflux disease, which is very commonly we see in day-to-day our practices.